Ava's driving?
Yes,
Yep.
Ava is driving. I think
That's
you
good.
might be out a different branch of that same superior. It looks in similar position as the vein you were just in.
Could be. Looking on ice, so.
There we go. Going
Yeah.
inferior.
And you know why? It's a big common vein. That's why. So you can
There
actually
we go.
see on ice here. I'll get a little bit better picture. There it is right there. We're using ViewFlex right now as our ice catheter. So you can see that's starting to go out an inferior branch of it. And then I'll get you a little bit more.
Great.
Again, there's yet another branch of
Superior
that.
branch.
Yep. And then there's
Nice.
even another one as
Another
well.
higher one. Yeah, looks like it might be
Yeah.
coming out there.
Which we'll probably need to utilize as well. So that's starting to go out one of them. We can probably go out either, to be honest, when we're, so there is
Okay.
that defining it, when
Sounds
we do
good.
the actual ablation. So the nice thing about bidirectionality with the Insight system is that we don't have to wait for tagging. Now, you still have to be somewhat methodical in terms of the moving the catheter around. We'll probably get some here. You can see here, I'm right at the posterior wall, right at the, probably where you would. Did I get something there? Yeah. Okay. Good. Cool.
Nice.
So let's come around back, show some more posterior stuff. So relatively normal-ish voltage. You know, traditionally we would do sort of voltage guidance to help us make this decision. So it's always interesting to decide whether you want to take out the posterior wall. There's some data that suggests that doing empiric posterior wall isolation may increase your chances of developing either stiff left atrial syndrome, or if you look at ENA wave ratios on echoes post, the patients potentially lose some squeeze of the left atrium. So my point being, I don't necessarily think it's great to take out the entire left atrium empirically. You can see here a lot of interesting areas of fractionation with actually relatively stable voltage. So if we were going just based on voltage, one might argue not to take out the posterior wall, but based on this dispersion, I 100% am going to. So potentially helps me feel better about doing additional non-PV, which all of us believe obviously is the right thing to do in patients who have persistent, certainly long-standing persistent atrial fibrillation. So we have a catheter out the coronary sinus that actually can capture the V through CS1-2. So if we need to pace the ventricle when we ablate the left veins, which causes pretty frequent pauses, we saw that a lot in the initial IDE for Farapulse, which I ran here at Penn. And so let's see here. So coming around, get some better contact here. So just looking to see here, pretty decent sized left atrium as expected for someone who is persistent. Yeah, and I would be shocked if this didn't light up. So there you can, again, Volta has sort of forced me to look more at signals than I did in the past for fib. Traditionally, I did this anatomically and just kind of went, but I think this has actually been particularly helpful for me for even visually looking at dispersion, which you can see at the electrograms now on a lot of the A and B poles. So let's come around to the right veins. So I try to track myself on ice. I'll apologize in advance. This ice is the way that we do it at Penn, which we flip things left, right. Our joke is that there's the right way, there's the wrong way, and there's the Penn way. So since you guys are here at the University of Pennsylvania, that's how we're going to do it. So if you're not used to looking at it, I apologize. But you can see here I'm sort of tracking definitely lots of interesting areas here on the posterior wall as well. So, and then I'm going to come to the right superior if I can. This is a little bit more anterior. May as well get this here while we're here as well.
Yeah.
And then you can see here, yeah, I'm right at the carina, actually. You can see on ice of the veins. So I'll come back a little bit and then see if we can prolapse in. There you go.
There you
so
go.
That's starting to go out. Sometimes it's nice how the grid just kind of prolapses into smaller crevices. So you can see here, again, we're mapping in Navix mode and not voxel mode. It's particularly, in my opinion, pretty straightforward. Well, one, obviously, I'd have to break open a sensor-enabled catheter to be able to get that. But for our purposes, it's perfectly fine to do it this way. It actually works pretty well in terms of visualization of the Faro wave catheter. So again, just defining more of this posterior wall. Some interesting fractionation here. Lower voltage signals as well. It's nice to go back to the same areas and validate that they are still showing volta dispersion. Shows it's reliable and reproducible, right? That's what you want in a system that's giving you additional targets for ablation. So let's come to the inferior vein, which I'll try to in a second. This is the hardest vein, obviously, to get with this with the ferrodrive sheath. So try to not be too. So here's some more. Again, that's just further going out that right superior. So I'll just define that further. Then let's come back and see if I can get that right inferior without causing myself any too much of a struggle. Yep, it's definitely interesting areas here. You can see on ice I'm close. So let's see if I can get my sheath up. Yep. And this, yeah, lots of interesting areas here. Let's back out that right.
Yep, headed superior again.
Yeah, just trying to get this thing to prolapse without falling. See
Yep.
if I can. See, it's right there. May as well define more of this floor. We don't need to come all the way down here, but we'll get all this while we're here. Huge left atrium.
Yep, grabbing all of these points.
Perfect, thank you.
This is a big left atrium.
Mm-hmm.
Back out that inferior branch of the superior.
Yep, agreed.
They're common, I guess.
Yeah, why don't we get some anterior stuff while I'm here? So let's spin us around. We'll start to define. Similar to the last case that we had just recorded, there was significant anterior dispersion. Now the harder question for me to decide is whether I'll target it or not. So we'll make that decision based on what we see. Keep coming around anterior, please.
Sure.
So here that's down by the valve.
Yep.
Coming back around further. So let's see. Yeah, there's a lot here as well. So a little later, so you can see the red tags that are just listed there as opposed to the blue, and the red sort of the highest levels of dispersion. So this AF Explorer 2 is able to give kind of almost like we look at scale for voltage, it's looking at scale for dispersion. So the areas that are the most interesting, which are coming right where one would draw anterior mitral line. So we've tended to notice we've seen a good amount of dispersion of this in the cases that we've done here at Penn. I think has also been reflected in the data from both Taylor and Restart. So our first patient that we did and recorded was a Restart patient, and this would be a Taylor AF patient. So it works out. You can see here, it's just kind of marching along as well. So yeah, pretty much very interesting signals here that are coming through the anterior left atrium. Looks like more scar than anything. So I'll get you a little bit more here.
Okay, grabbing these points.
It's almost like someone drew a line through. So it's kind of, it's a little bit easier when the map tells you that this is what's going to need to happen. It's harder when it's not, and then you just have to be careful because you want to be able to anchor any lesions that you do, because if you do kind of spot welding with a PFA catheter, you're going to increase the risk of flutters and weird ATs and stuff like that. All right, so I'll get all this stuff and then we'll try to get back around to that right inferior vein, which we were close to, just not there yet.
Yep.
And I'll just be careful as I come across. Yeah, so this is near the roof, right? Yeah.
Yep. Kind of near the superior there.
Yeah, and then spin me back around posterior.
Sure.
Okay, so let's see if I can get that inferior vein, and then I think we'll have most of what we need. Yeah, it's very close there on ice. I can see it. Yeah, this is it right here. So I want to make sure I'm not missing something, because this actually on ice looks like the inferior vein. So you can see
Is there
there.
maybe another
There
kind of
is, yeah.
projection? Okay.
Which makes sense why I couldn't get out the
Yeah, that does.
this is the inferior vein. So
Okay.
it goes to show you intracardiac echo. It's very
Yeah.
helpful. So
Especially when
kind
you
of,
have a common.
yeah, exactly. It's kind of a rotated atrium as well. So that's the inferior. So we defined all that. Let's go probe around for the superior as well. It's like a rainbow, this atrium right here with all the colors. So let's see here. We'll fill all this in. This is on the roof. And I can see, yeah, the superior is up there. So, all right. So let's take a look. There it is.
Fair.
So kind of funny takeoffs for these veins. So you can see there, it's starting to go out that superior as well.
Wow.
Yeah, so it's very vertical. You can see it on ice there, actually, right there.
Interesting.
So very widely separated carina. You can see of the right veins. So, all right. So sometimes it can be a little tricky. We're excited to get Abbott's version of sound so that we can reconstruct these atriums. Makes it a little bit easier. I think some folks who have already been using these on the cardo side are kind of used to it. We used to do this without having a sound shell or ice markers, so we're used to it, but it is helpful. Certainly for ventricular cases, there's a little bit more of that superior as well.
Great.
Looks good. And then all right, so Ava, spin me around. I might have missed some of the anterior right atrium, or anterior near the right veins, but
okay.
Let me see. Keep spinning around.
You want to see the rights? Here you go.
Yeah, it's actually not bad. I mean, I think I have most of what I need. You have all of the carina. You have the veins. There's probably maybe some. It's going to be close to transeptal, so I'll have to be a little bit careful. But other than that, I think this has all helped me with guiding what my ablation strategy is going to be. So, all right. So spin me around posterior.
Sure, posterior.
Yeah. So, all right. So that we got all that posterior stuff. Now we know where the right superior is. So I'll fill all that in as well. All right, and then all right, and then let's come back around anterior. So come back around with me, and I'll try to catch some of that anterior stuff as well.
Great.
Let's
maybe some appendage definition too.
Yeah, so let's figure out appendages here, right? So yeah, so this is appendage.
Gotcha there. Grabbing all those points.
Because this is looking like I'm going to be doing a mitral line on this patient.
Yep.
As well, so that's there.
Okay, you got your appendage.
Cool. And then down here is down near the valve. So this is probably, just look here on ice. Yeah, this is somewhat near where we would start. So maybe like tag A1, A2, A2, 3.
Sure.
Actually, do like C.
The valve there? Yes.
Yeah, exactly.
Okay. Let me do C.
Just for a target for our PFA catheter. And then
I grabbed those.
All right,
yep,
let's keep coming around anteriorly. We'll define the rest of this lower stuff. So now that we know where the right is, it's actually more like roof stuff than anterior. So I stand corrected. When I was looking at it earlier, I was thinking that my other vein was my inferior vein.
Yeah.
It was. I'm sorry, my superior was actually my inferior. So let's see if there's anterior, because we might be able to cover that all if we extend the posterior wall isolation a little bit more anterior than you normally would. There's a ton of dispersion up there, but I think we might be able to cover it all just with posterior wall isolation. But let's see what this looks like too, because I'm always on the fence as to where I want to do an anterior mitral line on a de novo persistent fib, which some people do it on everyone, some people don't. If I do it, then that'll be easy enough to be able to do both. But again, as we had talked about in the last case, not isolating the appendage. But it turns out there looks like there's a decent amount here as well. So yeah, good, we'll get all this. Yeah, there's definitely some stuff here. Let me keep coming around. Okay, that's out the superior here. Yep. So let's get all this voltage data.
Grabbing all these points here.
Yeah, there's a lot of dispersion here, right out of the right superior pulmonary vein, right this anterior area, the left atrium, which again, as I mentioned earlier, tends to be a pretty common case in the dispersion that we've seen in the couple hundred cases we've done here, Penn. Another branch of the superior there, it looks like.
Yeah. Getting that definition.
Yeah. then come around and get you some anterior stuff.
Sounds good.
So what I do like is with the auto tagging, I don't have to go back and then make sure that the rep tags it. This does it automatically. It definitely speeds up the workflow. So we're looking forward to when Volta has this integration with some of the other competitive mapping systems. So let's see here, which they're working on. And I believe from Biosense is going to be coming soon. All right, so we'll get all this. Yeah, this is another, we got 2 huge atriums today. So that's all right. That's why we're here. So certainly for these persistence, long-standing persistence or redos like our last case, this can be quite helpful. And I think most of us are pretty comfortable with treating PAF, but these kinds of long-standing persistent cases are still a bit of a black box. So I think anything that we can do to help us now that we have PFA catheters that can, really take out a lot of tissue in a pretty quickly time. It's helpful to be a little bit more elegant, though, than just anatomically doing it, in my opinion. So let's see here.
Getting that carina and underneath the inferior there.
Yep. Yeah, a little bit of dispersion here. We don't tend to see as much dispersion in the veins in general on the de novo cases, but let me come around and do this area too. So we'll get this. I think we should have everything we need.
Yeah, looking good.
Yeah, I agree. Let me just get a little bit more here. Just be careful I don't fall across.
Yep.
This. Okay. All right. Ava, spin me around posteriorly.
Yeah.
All right. And then I'm going to go back out the left veins. Am I missing anything?
I don't believe so. I think you got good definition along the carinas and the veins, along the roof and the floor. So looking good.
I agree. Everything looks good. All right. Let's switch out for the PFA catheter.